everybody. My topic for today is comparison of clinical efficacy of ICL implantation with and without use of an OVD. In introduction, I would like to say that phakic intracolumnar lens implantation is widely used for high myopia, even for hypermetropia and astigmatism. It is an FDA-approved technique. So to insert the lens, like any other intraocular surgeries, we use ophthalmic viscosurgical devices. OVDs are useful in two ways. Firstly, it maintains the anterior chamber. Secondly, it also protects the corneal endothelial cells. So, but the retained OVDs, if they are remained in the post-operative period, they cause blockage of the central hole of the ICL, and they also mechanically block the trabecular meshwork. So these complications contribute to high IOP spikes post-operatively and also high inflammation in the post-operative period. So the mean OVD technique, which is applied by experienced surgeons in recent years to reduce the occurrence of high IOP after surgery, and the post-operative recovery is rapid. So under the premise to further minimize the risk of OVD-induced post-operative complication, OVD technique can be replaced by non-OVD method, which is done under a BSS solution, continuous irrigation of BSS solution to maintain the anterior chamber. This was a retrospective cohort study of 100 eyes of 50 patients. All the surgeries were done by a single surgeon. The follow-up periods were on the first day, 15th day, then 3 months and 6 months. Each group had 50 eyes of 25 patients. Patients in the study underwent a thorough anterior and posterior segment examination, and the IOP was measured by non-contact tonometry, biometry was done, endothelial cell density was measured, and retinal assessment was done. The phakic IOL used was ICL, which is by a star surgical lens. Time taken for the surgery was also recorded for both the groups. Inclusion criteria was age between 20 to 40 years. Refractive error, which was stable, less than 0.5 diopter of change in past 1 year. IOP of less than 21. ACD of more than 2.8, and endothelial cell density was more than 2100. This is the preoperative data where we treated mean sphere of -10 and mean cylinder of -2 diopters. So the results were comparable in both the groups. Sphere, cylinder, and spherical equivalent were excellent in both the groups post-operatively. What we saw was endothelial cell density changes, which was higher in the hydro group as compared to the OVD group, but they were not statistically very insignificant. Mean IOP pressure was very high in the OVD group, while it was compared to the hydro group, it was less. On the first day, OVD group had mean IOP spike of 17 millimeter of Hg, while hydro group was only maintaining 15 millimeter of Hg. So to discuss this topic, 50 eyes were compared in each group. OVD group had incidences in 8 eyes. In 1 eye, IOP was raised due to low vault, and ICL exchange was done in that patient after the IOP was controlled by 1 month. 4 eyes had high IOP on day 1 and day 15, and 3 eyes were maintained with anti-glaucoma regime. 3 eyes had post-operative inflammation reaction in the form of cells and flares on the first day, and it was controlled by steroids. Out of these 3 eyes, 1 eye had a task-like picture, and it had corneal edema and hypopyon on post-op day 2, which was controlled by the steroids, and it was closely followed up, and the eye was quiet and no inflammation was noted at 1 month. In hydro group, there was no such incidence of raised IOP or any long-term inflammatory reaction. Comparing the time taken for the surgery, hydro group had mean time of 3.5 plus or minus 1.2 minutes, while the OVD group had a mean time of 7.1 minutes plus or minus 1.4 minutes. At the end of mean follow-up of 6 months, endothelial cell loss was 4.8% in the hydro group, and it was 1.7% in the OVD group compared to the pre-op ECD values. So to conclude the study, I will say that ICL implantation by continuous irrigation is safe and effective, but it has a little longer learning curve compared to the implantation done by OVD. But once we execute this practice regularly, the time taken for the surgery is significantly reduced, along with minimal chances of post-op IOP spikes and lesser inflammation compared to OVD groups. These are my references. Thank you.
So you have not mentioned which OVD you used.
Yeah, we have used HPMC 2.2%. Hydroxypropyl methyl cellulose 2%.
But using hyaluronate, it helps to take out the OVD faster.
Faster, yes.
So Any
No.
reason why you choose
That is
behind?
the one which we use regularly, and it is also little cost effective. But in the ICL surgery, the cost is anyways higher. But that is what we use in the routine practice, HPMC 2%.
Your post-operative or hypotensive treatment in both the groups was the same. What is your post-operative hypotensive treatment?
IOTIM, that is timolol 0.5%, but if it is not controlled with one drug beyond 1 week or 10 days, and then we would.
No, the routine post-operative
Routine is
treatment.
IOTIM,
And
timolol.
was it the same in both the groups? Even in the hydro group, you were giving the timolol?
Same, sir. Same. Because there is no protective effect of the OVDs which are present in the OVD group. So in the if we use OVD, it will protect the endothelial cells. Doesn't, yeah.
But was this calculations, these cases done after the learning curve or during the learning curve of using hydro implantation?
Like during the learning curve. It was done by a single surgeon, and
So any complications you had? Any complications you had
in the hydro group there was no complication that we
difficulties
noted.
and complications?
No difficulty, sir, I will say. The hydro group is much,
Anybody can do.
not anybody can do, but definitely you need to do some numbers of surgery to get used to the implantation and how the ACD is maintaining with the hydro or even with the visco, because it becomes little tricky while implanting the lens.
So your research question is efficacy.
Yeah.
So how do you do? What is the definition of efficacy in your study?
It is depending upon the efficacy. Basically is calculated by efficacy index.
Now, what do you mean by efficacy in your study?
Efficacy is the effectiveness of the treatment, basically. So how effective is the treatment, that ICL, how effective it is in both the groups. So it was quite equally effective because the visual and refractive outcomes were comparable in both the groups, sir.
So in conclusion, would you mention which would be a better technique? What would you advise people to do? Use a viscoelastic or not use a viscoelastic?
Viscoelastic is useful in the initial learning period.
But you said the study was done during the learning period itself, even for the hydro group. So
yeah, sir.
at the end of it, would you advise a shift over from the viscoelastic?
I would advise the shift from the viscoelastic to the hydro.
So, whenever we do a hydro implantation, the most important question would be that what is the bottle height? Because these are myopic patients. If you keep a very high bottle height, when you're on the topical, they don't tolerate it so well.
That's true. That's even with the cataract surgery.
The viscoelastic injection is easier because there is nothing going around there. So, what was your bottle height in your study? Because that will determine the tolerance of
The bottle height is the standard 175 centimeter from the eye level.
So you are actually, it's a bold move and a good study, but you could have included the complications and what are the difficulties in doing, and also it's high myops. No, if the bottle height is high, there is something called iris retropulsion.
Yes.
So it becomes very deep.
Yeah.
So if those things, if you could have included, it would have been a very nice study. But
Yes.
anyway, congratulations.
Thank you, sir.
Thank you.